This is the Etiology podcast. I am your host, Elka Kubaku, licensed social worker and psychotherapist. In this podcast, we explore divisive issues around food, health, and body image with the goal of mending relationships within the eating disorder recovery professional community and creating a space where a multiplicity of perspectives can coexist harmoniously. This podcast is uncensored and encompasses the political and ideological spectrum. If you believe something you hear is harmful or misinformed, please be respectful to the speaker. And also, feel free to reach out about recording another episode on the same topic from your vantage point. My hope is that if, as professionals, we can hold each other's stories with respect and compassion, we'll be better able to do so for our clients.
How do we know what is real? There are so many different treatment modalities, each with its own acronyms and catchphrases. There is also a large diversity of opinions around issues related to food, health, and eating disorder recovery. How do we know what treatment approach to follow? This episode is a dialogue between two guests who are both highly skilled and experienced in their respective and in some ways very different approaches. Abby Sarret-Cooper practices family-based treatment and dialectical behavioral therapy. She presents on these topics and has studied under some of the most prominent leaders in these fields. Rachel Lewis-Marlow is the director of the Embodied Recovery Institute, where she facilitates and trains clinicians in somatic, trauma-informed, and attachment-based treatment. They each briefly touch on their modalities and share how they determine whether an approach is useful, what guides the way in which they approach clients, the roles of confrontation, gentleness, and top-down versus bottom-up approaches. In many ways, this is a conversation about the science and the art of psychotherapy.
Thank you both for coming on today. It's fun to see you both again.
Thanks so much for doing this.
Yeah. Thank you. Can you start by introducing yourselves and what you do in the eating disorder recovery world?
Well, I'm Rachel Lewis-Marlow. I have a private practice, and I am a somatically integrative psychotherapist and licensed massage and bodywork therapist. So I guess we'll talk a little bit more about how that plays into the work I do with individuals or in my private practice. But then I also am the director of the Embodied Recovery Institute, and we do trainings for members of multidisciplinary eating disorder treatment teams in somatically based, very trauma-focused, attachment-based, and somatically integrative approaches to working with eating disorders and supporting recovery.
I'm Abby Sarret-Cooper. I am in private practice in New Jersey, and I'm licensed in Pennsylvania and New Hampshire. And I have been treating eating disorders for probably about 20 years, and I kind of fall under the umbrella of evidence-based practices. Treatments. So mostly I think of myself as a DBT provider and an FBT provider. I think those two align very well as they're both non-judgmental. And to some degree, they both take a agnostic stance as to etiology. And they both are somewhat behavioral, right? It's not very behavioral. So I've been trained by the researchers and the developers for both of those with advanced DBT trainings in eating, the applications for eating disorders, the applications for families, the applications for adolescents. And so I do a lot of family work. But I do treat across the lifespan.
Awesome. When you said we're agnostic as far as etiology, that brought me to what I was going to ask you guys is how you see or how you understand what is at the root of an eating disorder, or what's underneath it. So you can talk about what it means to be agnostic as far as that, and if there is any view of cause or etiology that influences the way that you approach particular clients. And then Rachel, you can share what that is for you.
Agnostic means we don't really know. There really has to be a perfect storm, it seems. What we know, the picture's filling out slowly. We do know that there are neurobiological, genetic underpinnings. because many people can have very similar context experiences and not get an eating disorder. So that biological piece has to be there for any other external factors to pull the trigger, right? The gun has to be loaded biologically, is how I see it.
When you're looking at treating someone, does etiology, or maybe not even etiology, but what is underneath it for this particular person, does that play a role in any way in a behavior-based treatment or not really?
That's a question you really can't say yes or no. And I think we have a cultural assumption, we have a historical assumption that there's a root cause. And my own experience with clients tells me that's not always the case, right? I've met with young people who got their tonsils out, lost some weight, and boom, an eating disorder happened because they had the genetics. And then once they were weight restored, once they had other coping mechanisms, there was no more eating disorder. And I'm not saying that's the norm, but I've seen that. So that's why I think being agnostic, not going in with an assumption, I think serves my client. Let them be the bearer of their story. Let me not come with assumptions based on my personal experience or any bias.
So you're approaching without an assumption of some kind of root cause, knowing that sometimes there will be and sometimes there won't. And it's up to the client to tell you that.
Right. And I the expression root cause, I wish I had another one, because it does have connotations associated with it. And so might there be other things that can contribute to the development of an eating disorder? Yes. Right? Can it be a variety of things? Yes.
Yeah. The root cause starts to bring us into depth psychology, which, Rachel, let's open it to you to share yours. And then the two of you are welcome to ask each other questions or share any thoughts on each other's.
So I think the first thing that I wanted maybe to say is where I think I agree with Abby about, there's so many factors that go into what creates a human being and what impacts a human being's experience of life and their response to that experience, right? So I think my approach, in addition to trying to look at all of these various factors, I'm also looking at sort of recognizing that there can be something that happened that maybe initiated someone's challenge with taking in nourishment from food. There can be other things that maintain that challenge. And then there's something that could be very different that's going to shift that relationship of taking in nourishment from food. And so the way that the approach that I use is one that is sort of a compound lens that looks at behavioral maps and somatic maps, which are close, that include biology and physiology, includes a lot about what's going on in the body, from reflexes to birth history to movement to genetics and epigenetics, and sort of just like the whole constellation of the somatic organization of a person, how that somatic organization supports certain kinds of behaviors that go into this very, very complex behavior of getting nourishment from food. And in between the somatic lens and the behavioral lens, there's also, experiences of cognition, of affect, of, relational organizations. There's all kinds of things that happen that are also sort of concentric circles between the somatic and the behavioral. And that what I have found, I've observed, I don't know how much I've read about this, but I've definitely seen it and experienced it, is that a lot of the patterns of being able to get nourishment from food, those patterns and those rules and those challenges or ease of getting nourishment from food are reflected in what is going on when people are getting nourishment from other sources, whether that is just sensory input, sound, light, smell, or relational sources of nourishment, love, approval, acceptance, nourishment, nurturing, protection, and that when I use this particular map of behavior, we can kind of nuance all of those behaviors, something that ends up looking like restriction. There are lots of behaviors that may be contributing to someone's inability to take in nourishment from food, and so we're looking at, what is the somatic underpinnings, what might be the cognitive, the relational, at any given point, whether it's being able to identify what you want, being able to ask for it, being able to reach out and get it, take it in, etc. So that's sort of a long answer to a singular question of, what causes it? Who knows?
Exactly.
What's going to help it shift? Well, it depends. And it's as much about being able to work with that person and explore their system and what makes sense to them and what do they need to achieve a certain level of neurological regulation that allows the body to even be on board with this idea of taking in nourishment from food. And that's one thing we do know, is that if the body is not oriented towards receiving nourishment from food, it's going to be a lot harder to get the volitional intention. It's going to take willpower to fight against what that body's neurology is.
Funny, I don't look at it as willpower.
Well, say more, because
yeah, I think willpower is to me, I hear it as a judgmental expression, historically been used judgmentally by clinicians, medical as well as mental health, right? But you just don't have the willpower.
Well, that's what I think we're actually agreeing there. It's like, it's not just about you don't have willpower.
Right.
But keep going. I'm sorry, I interrupted you.
No, I was just saying that some of the behavioral part, of course, when we have anxiety, we have fear, and folks with eating disorders have anxiety and fear. We know that exposure has to happen for all anxiety-related behaviors. And that's never easy. So in DBT, we term it as, willing versus willful. How can we get to willingness, right? And I think the expectation sometimes, I think the evidence-based treatments have gotten a bad rap, in a sense that there's lack of concern for how the person's emotional resources and ability to face those fears happens. It's just, we're doing this, full steam ahead, with a lack of empathy and warmth. And I don't think that's true. I think we help a person understand that to shift expectations, that the fear is going to sit there alongside new learning, right? Inhibitory learning versus desensitization, right? And all of a sudden, you're just not going to feel fear anymore. That you're going to learn something new too.
Mm-hmm. Mm-hmm. Yeah. So in a way, I think there's some overlap. My approach, which is that recovery is an additive process, which is about what do we add. And one of the things I'll have people come to my trainings who are DBT trained, and I was DBT trained and used DBT at a treatment center. And people used to think that I was like really against DBT. I'm like, no, I'm not against DBT. I think one of the greatest gifts of DBT is that it actually helps the clinicians stay in relationship with clients who are very hard to stay in relationship with. And it's because it is a mechanism that allows for that the relationship and the co-regulation is sort of the magic that happens. And DBT is a way in which people get to have that accompaniment while being scared. So with it, it's always about adding the attachment system. It's not about getting rid of these things. It's, can you feel this and simultaneously feel the co-regulation, and then eventually build the capacity for self-regulation, which is what we need, because we're mammals, in order for our digestive system to be oriented towards taking in food. It is physiologically paired with our attachment system, physiologically and neurologically. We're mammals. If you don't have a relationship, you can't eat.
I don't know if I understand that, in the sense that certainly I understand about the sympathetic and the parasympathetic and how that right? You can't eat when your arousal system is hijacked.
Exactly.
But the attachment system, I think, is something different.
And I do want to say, like, I think people use different words for different things, but I'm talking about, like, on a somatic level, that part of our system that both can determine whether a stimulus is a stimulus that I want to move towards and connect, or I need to disconnect from, right? So there's a part of our nervous system that makes that assessment, that social engagement system, through our senses, our sensory system. Of course, are always, we're sensing, just as you mentioned, like the empathy, the prosody. Our clients know, not from the words that we say, but how we say them, whether or not their system can feel safe with our system, regardless of how safe we feel we are. I mean, their system is constantly calibrating whether or not, this is, and it's happening so subcortically. We recognize it in the breath. Like, there'll be a spontaneous breath and there'll be a settling when they feel understood or they feel gotten, regardless of what we say, right? So those kinds of interactions, those somatic interactions that are happening, either through mirror neurons or right brain to right brain, subcortical, are impacting our digestive, our nervous system, that balance of sympathetic, parasympathetic, that makes us more receptive to taking in nourishment, whether we're salivating, whether there's tension in the jaw, whether we can swallow, just all of those very, very biological settings that support engaging with the behaviors of eating, of selection, ingestion, digestion, absorption, and elimination.
I want to bring it down for a moment just to see that I'm understanding what both of you are saying. In terms of how we approach understanding what's happening for this person, both of you are approaching it agnostically. We're not approaching it with an assumption of what this person is, and also holistically in some way, that there can be multiple things contributing to this person's experience. What we're starting to enter is a conversation about discomfort and what role it plays in therapy. And both of you are saying we need discomfort in therapy. And part of the work that we're doing is giving the person or helping the person build capacity to be able to be uncomfortable and do the thing anyway. In this case, the thing is eating. For you, Abby, the way that we increase a person's capacity is by building coping skills and exposure. So helping them in a gradual way get there. There's something more.
Yeah, obviously support, right? And so many of the things, Rachel said, I find equally important, right? The mirroring and the responsiveness. And so I don't think it's formulaic, like it's skills, it's coping skills. That sounds formulaic.
Yeah.
And I don't think it actually plays out that way in the treatment. But I think it's interesting about what you just said about about this dialectic, about discomfort and how we approach discomfort. I wonder if many, many clinicians are afraid of discomfort themselves in the room and look to avoid it. There is some literature on that. I just wonder if many times the idea about how gentle we have to be is both fragilizing to the client, as we would call it in DBT, and also about our own avoidance and difficulty with regulation and tolerance of difficult emotions.
Was there something in what Rachel was describing about approaching holistically and attachment and the role of a relationship that brought that up, or was it more something that comes up in this conversation outside here?
It's interesting because, we're each individuals. We each have our own histories. We each have our own styles, personalities, right? And so what is it we're drawn to in certain treatment approaches, right? And I also notice I have a reaction to what feels like I've got a life-threatening situation and maybe I don't have time, right, to do as much, to go as gently as some fantasy might allow, right? Like this person is in a life-threatening situation. I must find a way to help them take in nourishment. And the safer we get behaviorally, biologically, the more we can make space to then say, how did we get here? And go back from there. Right. So I'm sometimes I wonder about where the urgency is and where there's a sense of I'm trying to watch my words. I can be a little flip, a little of that irreverence from DBT. I'm trying not to be. But I'm just wondering where Rachel feels any sense of urgency, and what do you do with that?
I like that question, and it's one of the questions that people do to give me, right? It's like, well, what if this is happening? It's like, well, my baseline is people have to be alive in order to do this work, right?
Sounds like DBT, yeah.
Right, like, I'm not saying that we don't do work with dead people, but it's a very different discipline, and that's not really what I'm doing here, right? I don't want to say things can't be done, but that's not my scope of practice. So yes, we have to do that. There's several different words, and I'd like to parse some of these words. There's urgency, there's fear, there's avoidance, and there's gentleness. And I'd like to make some distinctions here, because I think that fear is antithetical. When we are in a state of fear, it is very difficult to have bottom-up support for the behaviors of taking in nourishment. I think we can be urgent, or we can be effective, right, without having to be afraid. We can be in danger and not be afraid. We can respond to the danger more effectively when we aren't afraid.
Absolutely.
And so I think that...
But we can also act when we are afraid. It's courage. That's what courage is. That's what bravery is, right?
Even there, when someone is acting courageously, the root of the word courage, it comes from the French word for heart. It's what we're doing is that in this situation, we are adding heartfulness. And so we're advocating, we're working towards something, not just against something we're afraid of. We're moving towards something, right? And which is I think, a very healing and a very important and empowering thing to do, that requires a certain access to a certain part of a person's humanity. One of the questions, and so I want to get to the difference between what I consider gentleness and avoidance or hesitancy. I think people can be unrelentingly gentle, and that's, you're not backing off of anything. We're going to stay right here. And it is sometimes penetrates through somebody's armor and fear, so that gentleness doesn't have to be backing off, right? And so I think that sometimes it's the connotations that people have around what they're hearing of, like, am I not addressing or keeping somebody on task, of like, Do you need to eat? Yes. And what I find, if I'm going for, there's like baseline, you got to get this in. Once we get past the baseline and I know you're okay, right? Are we holding more urgency than is necessary? Can we start doing this more like cellular change, not just behavioral change that's congruent with the behavioral change, so that you get really sustained recovery?
Wait, behavioral change that is not change?
I don't think I said that.
That's what I'm trying to understand.
What I'm saying is that there's lots of different levels of behavior. If we think about it from as human beings being a sensory motor loop, we take in information, we respond to it, whether that information is coming internally or externally. Sometimes it's coming in very social information. Sometimes it's purely energetic light waves or energetics or whatever. We're still taking in information and we're responding. Sometimes that information comes in and it makes a loop that's in the brainstem. Sometimes it comes in and it goes up into our cortex and our thinking brain and our cognition, and then we have a response. We have it's all sensory motor, and every motor reaction is behavioral. So
behavior is also thoughts and feelings. Thoughts, feelings, and actions are all behaviors to a behaviorist.
Yeah, okay, right. And somatic, there's somatic behaviors, and it's about, cellular behavior then we might be thinking about. And so I'm just saying that the more congruency there is. So if I have a volitional movement to reach for food, right? That's doing one. If I have a reflexive movement that is to pull away, if I'm holding that, I can override that and behave in a certain way. I can, but then I'm going against the current of a deeper somatic pattern. It means that I have to use a finite source of energy that sometimes people run out of. I mean, this is why we see a lot of recidivism. People who go through programs, they get these skills, they do the thing, and they're doing it for a while, and then they don't have the energy to maintain it, or something overwhelms them. So I think it's just an added layer. It's not saying behavior change isn't change. It's just, what level is that behavior happening? Is it happening subcortically behavior? Is it cortical, frontal cortex driven? Is it top down behavior change? Is it bottom up behavior change? And
Can you translate? But just imagine for a moment. So I'm your identified patient. I walk in. Can you talk about what it would look like for me when you're talking about subcortical versus cortical change? What does that mean practically?
So if I'm looking at what is your state of regulation, right? Are you how anxious you are, or how, right? Let's say that. How is fear manifesting, right? And it might be manifesting with certain thought patterns. It might be you might experience that fear as an emotion, or your body may be manifesting that fear in either muscle tension or fascial tension, or shifts in your peristalsis, your heart rate, right? Mm-hmm. Fear can be manifesting in all of these different layers, right? What I might do is I might offer you certain kinds of sensory input that gives your body, let's say if I'm providing proprioceptive input that's helping your bones know that they're connected, right? And that's coming up through your body, it's not going all the way up to your frontal cortex, it's coming up, and it's like, oh, I feel better. And there's a breath, and there's a shift, and there's an increased capacity actually to listen, to hear, to see, to think. I did this with a client at a treatment center. We actually did a whole thing with a sensory kind of sock, and just in gave her something to push on and, that bottom up, now she was actually able to follow a conversation, right? So that's bottom up, and it's not coming from a thinking thing. On the other hand, you might come in, be really, and I might guide you. I might say, well, I wonder if you could just take a look around and, some of that guided mindfulness, right? Of helping somebody orient, but it's coming top down. It's like they are hearing the words and they are following the language, right? Or I might even say, how about if, you think of a time when you felt comfortable. And so they're using more cognition and thought processes to then impact their physiology. So that would be a top down.
So in bottom up, you're letting me do something physically with my body, hold on to something or feel something that is then shifting the way I feel and my ability to, in this example, take in food. And in top down, you're doing something with my mind and my thought process. Okay.
Yeah. And just to say that DBT incorporates both directions as well. Like, so the whole mindfulness module, right, is teaching people about grounding and using that feedback mechanism of the breath to tell the brain, right, that we're okay, we're safe. And the tip skills for distress tolerance are about, say, taking ice cubes and using them on your temples or your neck to have that shift to the system, right, to get that jolt, using physiology as well. I think what I'm curious about is, though, one of the things I like about DBT, and maybe this says something about me, is that it gives me a framework as a clinician working with very complex, right, very, very people with great challenges, people who are really suffering. It gives me a system, right? Not a rigid protocol, but a way to think of this, conceptualize, and address it, right? Yeah. Similarly with FBT, it's not going to look the same in every family, but there's going to be a solid ground to stand on. And so I think that I'm wondering, where's the system? Where is a method that we can employ this approach and test it and make it even stronger and better?
The embodied recovery for eating disorders approach is not a specific methodology. It is a way of coordinating many different approaches to be able to say, so for example, if what we're looking at is assessing the behavior, the eating disorder behaviors, and we look at it through the lens of the action cycle, we're looking at it and saying, okay, we're not just looking, is this restriction, is this binging, is this purging? We're looking at it from the sense of, is there clarity about hunger, fullness, preference? Like, how is someone even knowing? Okay. Then we go to the next stage, which is effectiveness. Is like, okay, let's assume they know they're hungry. Can they actually ask for it, go to the grocery store, select it from a menu? Are they able to express what they want?
Yeah.
Once they want that, if let's say assume they can, then can they actually take it in? Can they ingest the food? Can they digest the food, absorb it, eliminate it? And then the last stage is completion. Can they actually stop? Because we need to be able to do all of those things in order to get nourishment from food. And so what we're looking at is breaking down, okay, when do the eating disorder behaviors, urges, anxieties, when in that cycle are they coming up? And what is the response, right? So that, because we could be restricting because I don't recognize that I'm actually hungry. I can't tell the difference between internal cues of hunger, tired, thirst, anxiety. I really don't know. And so it never occurs to me that eating would make me feel better or think better, right? And
so my question is,
Yeah.
how do you treat that? What do you do with that? Because
Right.
I think that so many of the things you say and you've described, we also take as an understanding in DBT or
Right.
FBT.
So the
They're
thing is,
accepted.
if we understand that that's where the issue is coming from, we might look at, okay, what we need to do here is an interoceptive awareness curriculum. Or we may need to, it may be that's what's going on. This is a sensory processing issue, right? And so we need to include OT and maybe some kind of movement or craniosacral therapy. It may be that the
Craniosacral therapy?
the hands-on therapy that works with the nervous system to help. It works very well with sensory processing, OT, to increase sensory processing integration issues. It's a hands-on therapy that works with the central nervous system. It's a whole discipline. So I can give you more information about that. The other thing that may be going on is that there's a lot of trauma. And so this person listening to what's going on inside their body, there is so much still terror that the thought that comes up when they have to listen inside is, I'm scared. And they think, and what comes up is, I'm scared of my body. And one of the things we say is like, maybe you're scared of your body, and maybe also your body is scared. Let's listen to your body, how it's expressing fear. And then maybe we need to do a somatic trauma therapy to help, and go into. So it's like we're looking at all of these different things that may be contributing to that. It may be that, sometimes birth trauma has a lot to do with people's organization of their central nervous system and all of the primitive reflexes that impact the information they're getting from their gut up to their brain. And so then if this is a result of a constitution that has its roots in birth trauma, well, I'm not going to do talk therapy to try and help you believe that. We're going to do.
How would we know that?
How would we know if they've had birth trauma?
Yeah, I'm not familiar enough to know whether or not we have direct, not correlation, causation, right? And an understanding of how we would get from, and what we're calling birth trauma, right? What's the definition of that, and how does that develop into an eating disorder? And if we have some data around that, I don't know.
I can't quote you all of the data. I do know that this is much more in the field of occupational therapy. And there's definitely data about birth history and how do we know if someone has birth trauma? You find out if they've had, cords wrapped around their neck when they were born, cesareans, and you want to look at whether it's a planned cesarean or an emergency cesarean. Was the mother put on fetal or on bed rest? There's all kinds of things that set up the patterns of the reflexes and the movement patterns. Was it a vaginal birth? Was it a fast birth? Was it a very slow birth? All of these things set up the somatic patterns of movement that support behaviors such as reaching out for what you want. If, for example, somebody has food aversions and we trace it back, it goes to I don't like to prepare food, and they have trouble preparing food. And some people, what we recognize is that actually bringing their hands to their midline is very dysregulating to the nervous system. They have trouble crossing the midline. So anything that requires hand to midline action, including getting food from a plate up to the mouth, cutting food, preparing food, it's going to create an anxiety in the nervous system that happens so fast that what we see is we can see it on the cognitive. It's like, I think about having to do that and it's like, I don't want to, because there's the body is already.
We do so many things with that positioning.
Right.
Do you know what I'm saying? That have nothing to do with food.
And that's why we look at how is this person behaving in all of these different domains? Again, it's like to see where is the bottom-up support for these behaviors. I'm not saying that we don't use the same skills that DBT uses. It's just saying this is how DBT might want to do it. Well, but we also, if there's a yoga therapist on the team, this yoga therapist, it may be like these poses are going to really help build the capacity to get the bottom-up support for the behaviors that this other discipline is trying to promote.
Yeah.
I guess where it sounds like it feels like it doesn't work for you.
I think there are certain principles of somatic understanding and understanding neurobiology that we have well established at this point in time. And I think other things we haven't. That we make assumptions from the theoretical to the practical, right? And I don't know if we can assume these things actually do what we're hoping they will do. I think we need a much greater body of research. Like, for instance, in my training with DBT, I learned about the half smile, which I'm sure you know about, right? And how that has a neural feedback to the brain. If I am going into this, if these muscles are moving, right, then I'm feeling better, just a smidge, right? And if I hold the pencil in my mouth, I'm going to activate that. And so I know that there's been the research showing the efficacy and showing the neurobiology.
Yeah, and that helps you know something. And it sounds like
right, because if someone's put a pin their hope
about something,
yeah, people are putting their resources in, their time, their money, their hope. And if we're calling it a science to be a therapist or a psychologist or whatever, then I want that. I want to give them that knowledge and that. Again, to me, science is our best hope. And it's an iterative process, right? But I think so many of the things you have spoken about are absolutely within the evidence-based treatment providers have that information and are working with that information. But it's necessary, but not sufficient, right? So that's what I'm saying. Where do we take this? And where is some great data, right? How do we develop data?
Do research. That's how we do
right.
it. Right. Yeah. Right. Yeah. So, here's the thing I would say is like Marsha Linehan had an idea. She observed things and she experienced things. And then people did research.
As she did.
She did. But she got right.
Well, yeah, she developed smart. I don't know how, but developed the whole lab and.
Yep. And then what happened? Yeah, she did it. She had an idea. And then she got research and data to support it. And then people took that and they applied DBT all over the place where there was no research for it. There was no evidence. Just
absolutely.
Right? Okay. So there is research, not necessarily in this field, about the relationship between movement and cognition and reflexes and sensory integration. And there's more research happening on the sensory system and RFID. And so I think it's a growing body of knowledge. It sounds as if your concern is that I'm somehow promoting this thing that's going to fix things and people should abandon what they know and do something that's like woo-woo and doesn't have any basis in science.
No, I'm saying this. I'm hearing certain things that are absolutely congruent with the underpinnings for DBT and other approaches that do have an evidence base. That there are certain universal understandings at this point about the body and the brain and the connection and about so many things.
But there's so much here that I want to dig into. So now we're starting to bump into the how do you know question and what is a legitimate way of knowing. And alongside that, I want to hear both of your relationships with these, but bear with me for a minute because I'm still kind of articulating this for myself. But one place in terms of the how do we know question is how much do we trust personal intuition? How much do we trust our own sensitivity to the environment around us and the person in front of us? Or on the flip side, how much do we need to look to objective measures and empirical research? So that is really the big question. And I'm sure we all, myself included, have some sort of relationship to both of those things. Let's start there. Can you both talk about what that brings up for you? The difference between the either depending on our own sensitivity and awareness, and when we come to that more, I don't know if Rachel, if you'd call it mystical understanding, because it sounds like you have a pretty like tangible sense of it. But when we come to some of those things that are difficult to study scientifically and that take a massive amount of resources, and maybe those who are in that space are sometimes less involved in the research field, though not always. How much can we trust that, and what's our way of relating to that? And also on the flip side, how do we relate to science, and how important is that when we're approaching the person in front of us? And oftentimes the starting point is like science is the way to go, and therefore we need to justify things in terms of science. If we just take as our starting point right here that there are different ways of knowing, and that both can be valid and important. Can you both share what your relationship to both of those ways of knowing is?
I think one of my concerns is in the last 10 years or so, there's been an insurgence of anti-intellectualism. And that worries me for our field. I mean, I think of psychology as psychological science, right? And I think of that, when we have an individual experience, right? That's an N of one. And so our job is then to find more support, do some research, find out, are there other people that have that experience? And then how can we generalize from those experiences and see if they are universal or at least widespread, right? But that intuition or instinct or even one person's experience is not an end. It's a start, right? It can initiate inquiry. And it has felt, similar to what's going on with the Maha movement, right, in medicine, right? That there is this, again, anti-intellectualism and not understanding that science is a method and a process. And I think in my own personal experience, having had therapy that, asks ad nauseum about my relationship with my mother, but didn't help me eat. Right? And didn't do what Rachel does, right? Explore any of the somatic experience in my body. Didn't do that either. Right? And so I think that there are lots of ways of knowing things, but what are we using them for? Right? Like people talk about believing in something. I'm like, well, that's religion. That's not science. So I wonder when people say, well, I don't believe that. I'm like, hey, we're talking about a different realm, different questions.
And this was part of your question earlier. You've been in the type of therapy that had a theory that maybe sounded nice and felt really kind of deep and complicated and didn't address what was actually right there. And there's also a value system there. Can you identify what the value is when you talk about intellectualism and science? What makes that really important?
It says that the problem at hand, we are dignifying the problem at hand. We are validating the problem at hand as being worthy of our time, attention, our best part of ourselves, all of ourselves, to explore that, to find answers.
So science demonstrates that we care about it and that we see it as dignified and worthy of attention.
Yeah, I mean, I think about it as thinking about the Enlightenment thinkers, right? And how they stopped thinking that things were about humors and God and believe that we could explore the reality around us in ways that could measure, that could identify, that could bring solutions.
So the dignified aspect to it is, I mean, in some ways, and tell me if this is accurate, it's in contrast to the humors or maybe even the witchcraft that mental illness was seen to be in the past that were very demonizing, that there's this kind of mystical, intangible thing that's wrong
That's
with
right.
you.
And
And what
it's not
science
that,
does. Mhm.
it wasn't that long ago that some very serious concerns were attributed to bad mothering, right? Autism, schizophrenia, we could go on, including eating disorders.
Yeah. And so what science does is it turns it into a tangible thing that has a system for relating to, or a pattern or something that we can observe, rather than this like mystical or intangible thing that's just wrong with you.
Right. I think about it even in medicine. We have a lot of people that that have unexplained symptoms, especially since COVID. Right? But things like POTS and dysautonomia and Ehlers-Danlos, MCAS, like we could go on. And doctors have a history when something doesn't show in the blood work or their tests, well, it must be all in your head, or you're not trying hard enough, or because I can't find anything, as opposed to our tools yet haven't evolved to the point where we know what we're looking for. So I believe you. There is definitely something going on here. And now, we're going to have to let you guide us, right? Rather than being dismissive. And I think we did the same thing in therapeutic circles, right? Where we made assumptions and we blamed without a full understanding. So that's why I say Rachel, what Rachel shared about so many of these biological and neurological functions. Yes, absolutely. We now understand a lot of this. And now what do we do with it? It reminds me of psychodynamic in that, we need to talk about this and we need to process your trauma. And people could talk and talk and process and not improve. Right. So here we have some things that we kind of understand, and then how do we improve? And if we're finding success, then let's do the measurement and let's force people to pay attention in a way that's actually going to give us some data that we can hang our hats on.
Right, absolutely. Yeah. So can I add and try and respond? I think there's like knowing, how do we know something and how do we know about something? And then how do we encode it? Right. And I think science is amazing at helping us parse things out. I think of science, and this is, again, you're asking what does this mean to me? Right? So, my little N of one of me, I think of science as a way of knowing something, of exploring something, of understanding something. It's a method, right? It's not the subject, it's the way in which I'm interacting with it, and it's very and there are certain aspects of life that are really well suited for understanding through a scientific lens. Just like there are certain aspects of the human experience in life that are really suited for understanding through poetry. Different. And science and poetry can explore the same subject. Sure. It's just that it gives us, it's a different way of interacting with it. And it helps people know about that thing and know themselves in different ways. I don't see it as an either or. I see this as how do we add? And what I'm hearing Abby saying is, let's add scientific understanding of what I may know through experience or through report or through, my own anecdotal experiences, is like, and I'm putting together this piece of science and that piece. I'm weaving different scientific information gathered from different disciplines that hasn't necessarily been woven together for a shawl in psychotherapy. But, okay, let's see, how it applies here, just like DBT worked here and now it's being applied here. Does it work here? And like anything, nothing works 100% of the time for 100% of the people. And also, I think, Abby, as you said, having a methodology that works so that it's authentic to the provider in the way they understand and they encode, that is probably one of the most important things. And one of the earliest researches that was, research that was done was like the relationship between the provider and the client is what is the best predictor of the effectiveness of the treatment, right? Mm-hmm. And so, I have people, and again, okay, I'm kind of trying to wrap up a bunch of different points here. Abby, you said, what do we do if we've got this information about the body? Well, we work with the body, and we work body to body. That's not going to be something that every provider wants to do, is able to do, even believes in. But what I've tried to do is to say this is where it's helpful to have people who speak the native language of the body, and they can speak body to body in a way that is congruent and with what is being the relational dynamics that are happening cell to cell, body to body, are congruent with the relational dynamics that maybe you're working with person to person, or we're working, right? And that's what this study is. That's what this model is being able to say, or it's not even a model, this approach is saying, okay, this is the relational dance we're doing over here. How do we support that congruently so that we were talking about the difference between like belief, it's like, for something to be true, it's like it literally, like, when a line is true, there's this alignment of like what my body is feeling, what my emotions are feeling, and what my thoughts are saying. There's like, it's all true here. And how many times have we heard a client say, well, I know it's true for you, but it's not true for me. Like, I know you're allowed to have your feelings, but I'm not allowed. My truth is I'm not allowed. And it's because somewhere that thought and the feeling in the body, it doesn't line up, So this is about how do we work in all of these different ways we're organized as a human being, so that we're all kind of working to support change in a congruent direction. And yes,
right. And in a way, I think you and I are having different conversations. Mm-hmm. Mm-hmm. Because I agree with the need, the relationship is paramount, and relationship skills have to be, they're our first tools in any approach, right?
Right.
Mm-hmm. But you said something about, well, it's got to be what the therapist likes, believes in, and I'm like, no, it doesn't. Actually, that's not true. My point is that if a therapist thinks that basket weaving is going to heal somebody, they have no business working with people with eating disorders, right? It's not simply, I'm taking an extreme example to illustrate.
That's not what I meant, but there are many evidence-based practices, CBT, DBT, sensory motor psychotherapy, they all have evidence to support them, but I'm not going to be a good CBT therapist. That's not the way I work.
That's different. Skill set is different than like, believe, right? And people can learn, right? The whole idea is similarly, like, I'm about to get my hip replaced. So they have found certain methods of hip replacement lead to better outcomes than others, right? I want a surgeon who is learning those new ways, regardless of what he likes. If he still likes to practice the old way and do the old surgery, I don't want to go to him.
Absolutely. You don't. It's not going to work for you. That's the client and the provider need to be a really good fit. Absolutely. Alka, you look like you.
I wish we had like 3 hours for this. Abby, there's a reaction that I want to go into. Rachel, there's a gap in my understanding. And Abby, I think this will address some of what you're describing as well, especially when we talk about like talking about different things. I think we're also starting to encounter really different and both valid ways of knowing the person in front of us and the world around us. And Rachel, you started, I forget the exact words you used, but you started to say something about being a good fit for this type of work because there's a type of, I forget if you described it as like body to body contact or like there's something that you're in touch there that not everybody is. You've been predisposed to the type of work you do now before you started doing it. Is that accurate?
Yeah. Yeah.
Can you talk about what it was like to be you as a, and I'm going to put my own words to this. You can use the words that best describe it, but what it was like to be you as somebody who's maybe very energetically sensitive or is picking up to things that are more subtle than maybe other people do before you started this work. And when was the moment when you started to realize that this is actually a gift that can help people?
Oh, that's a hard question to answer. I don't know if this is an answer, but so I started my undergraduate in psychology and I transferred and I finished it in dance. And like understanding the difference between a technical dancer, like someone who's amazing technical dancer, and watching them and being like really like be able to be impressed with the technique versus somebody who is moving and moves me, right? And that I am changed in their presence. Right? There's that. The first massage I got where, oh, this is feeling good. And then you're working on my quads and I burst into tears and I have this emotional reaction that has nothing to do with anything other than energy being released from the tension in my muscles and having these massive like emotional responses. Having my voice teacher start every semester by sitting down his new students. And this was a man who'd had a stroke and you could barely understand him speaking. But he would sit us down and he would say, you don't have to do anything. I already love you. Right? And that we come into the world knowing how to make sound and we're taught how to sit down and be quiet. I'm going to help you remember how to sing, right? So these are like huge, impactful mind-body experiences. Having someone teach me or show me that I could initiate moving my body forward and backward from the organ of my heart, not from the muscles, my skeletal muscles, but from the organ of my heart, and having my heart be caught in somebody else's hand, right? And what that just was like, okay, now the whole world is different. Like I have to like recalibrate a whole bunch of stuff and all of my mind has to shift. And what I know to be true about myself and the world around me, you know? So I collected these experiences and it was transformative change that happened in micro moments, in micro movements, in micro sensations that were completely life and world changing for me. So that's when I realized the power of that kind of interaction and to be able to, what it takes to help bring somebody into a place where there's enough spaciousness in a moment to have that kind of shift of awareness and experience, what it takes to be the kind of presence that allows for that kind of change. That's like transformative change. It's not just like thinking change. We can change our thoughts like this, but to get that thought to be congruent right? I can say, think of a purple elephant. You can do that. It doesn't mean that, right? It's going to stick. And so what was it like to have that orientation in the context of people who don't have that orientation? For a long time, it just made me feel crazy and that there was something wrong with me. And I think it really wasn't until I started working in eating disorder treatment and I had a clinical director who was willing to kind of let me do my thing, and people were shifting and they were things were happening, and people were not just looking at me like I was crazy, but that what I had to say might add something to what they were doing. I'm not taking away from anything. It was just, how do we add that layer?
Thanks for sharing that. How are you both feeling?
Fascinated, interested, curious.
Thank you for creating space for this conversation. I mean, I really appreciate you doing that, Elka.
Yeah.
You are a unique individual, Elka. You have a remarkable ability to hold space for multiple perspectives and ideas at one time, and to have everybody feeling accepted, welcome. And you pull threads. You are so wonderful at weaving.
Thank you so much. I really appreciate it. Thank you both so much for coming on. Yeah, I wish we could keep going. We'll talk again. Just real quick, tell our audience about where they can find you and what they can learn from you. Like if you are accepting clients, if you're teaching any courses, any of that, and I'll put links to all of it in the show notes.
I am in New Jersey, and I am at abbyscoop@aol.com. Abby, like my first name. Scoop is a contraction of Sarret-Cooper at AOL.
I'll link it all so you don't have to spell it out too hard.
And partners in counseling. But I'm very, very active in the Academy for Eating Disorders, and I've been in leadership, and I often present at their annual International Conference on Eating Disorders, and it's a wonderful place of incredibly generous professionals. So
I'm not taking individual clients right now, but I'm in Chapel Hill, North Carolina. The Embodied Recovery Institute is holding trainings. We're going to be in Chapel Hill. We're going to be in the DC area. We have an online introduction. We're going to be around. And I'll be talking at IADEP and at Meta this year. But there's different resources on the website, some different podcasts.